1, 2, 3. Let's see, works or not. 8, 9, 10, 12, 13, 14. Oh, it's done.
It's
Yeah.
only in the connection.
So your connection.
No, it's
yeah, the route
connected.
is covered. Yes, get someone. Yes. Maybe it's blocked. What the flag? The route maybe blocked.
Is this fine?
Video streaming. Because it's video streaming.
I zoom in.
10 of these? Shut down. Okay, it's charging and it's off.
The router is not good. Nothing is working with this router. We have to solve it professionally. Thank you. You can come as we finish work and solve this problem whenever you finish work. I appreciate it. Okay, what did you say? This lecture for you is not new. You know that younger. Yeah. So I don't know if you know.
Thank you.
Okay. No, no. Actually, you can. All right. Switch off the yellow light. Okay. The topic of today is anterior defect. Can you unzoom a little bit? Unzoom. Yeah, perfect. More if you can. That's perfect. All right. We have so many scenarios. One scenario is repeating itself is for teenagers, and teenagers are more prone to accidents. And in our literature and history of implant dentistry, we do not suggest placing implants on teenagers. We prefer when they are 18 plus. So this 2 hours today is dedicated to that group of people who are below the age of what we are used to, and they have these accidents. Now, looking at this scenario, I would like the participants, if you can guys come closer to me so your opinion will. Come on, us here. Okay, what do you observe here?
Bone defect in the anterior region of the central incisor.
Okay.
And there's also change, bluish, change in discoloration in the gingiva.
Okay. Keep talking. Okay. What else do you observe?
Also, there's the oral hygiene of the patient. That's another thing, gingival inflammation, generalized gingival inflammation. That's what I observed.
Okay.
Thanks.
Do you have any classifications? Do you see something you want to classify? Speak. Want to check the bone level in a radiographic manner, you mean, or with the manually with the probe?
We can check for both. But for once we open the flap or doing anything, we remove this soft tissue.
So prior to, no, when I said manually, I didn't say open a flap.
You mean with the probe check the
I don't know. What do you think? What are the ways to measure the bone? With a probe, okay? Because you said radiography, right? I said beside radiography, you also can do clinically, yeah. So how would you do that? You put the probe against the soft tissue, go till your probe stops. Yeah, yeah, and then you go all 360 degree to see the depth of the bone. All right, then what other measurements you need? The level of the bone at that, you mean crystal bone here and here. Why would that help you? For the papilla. If that is not there, you will not make any incision touching this papilla. Actually, as time goes by and we are seeing more papillary loss, if we can stay away from the papilla while placing the implant, that is our first choice. But if we cannot, then we look at the crystal bone, mesially and distally, and then we see if the crystal bone is not there, we have to think of, we discussed this last week, we think of uh, uh, entering the soft tissue from the crevice and elevating all the soft tissue. No flap. I'm not saying flap. You remember last week's method, how we separated the bone from the soft tissue without cutting it? It's like a tunnel, but we didn't make an incision. We just went from the cervical area and we separated the gingiva and we moved the whole soft tissue buccally and palatally wherever you want. And then we did the procedure. So those are the cases, those are the methods by which you can avoid cutting um, uh, the papilla. All right, so those are the measurements. Financially, of course, you need to measure if the patient can afford it. Uh, Time-wise, opening-wise, how much the patient can open the mouth, time, how much the patient can sit on the chair. These are teenagers we're talking about. So and it's in the front of the mouth. So opening and, yeah. Please, the whole, loud and clear. You mean you enter through this opening, right? Or no? Okay, so what do you do with this opening? Not yet, but it can heal. Yeah, it will heal. Yeah, so you wait for the healing and then don't enter from here. Use another, okay, entrance. All right. Give the mic to the next person. So how do you hypothesize in this scenario? What can, if you do what will happen? Give us a hypothesis. Anything. Keep the mic closed and just give us a hypothesis. If I do this, this will happen. Ortho treatment, okay. Okay, so if you take the, okay, perfect. Yeah, it will not be a good contact between the central and the lateral. Pass it to the Dr. Neshat. Dr. Neshat, you know what's infer? Tell us, what do you infer from this? This is 12-year-old girl who was hit by a water bottle in the school, and they cannot find the tooth, and it's around 8 p.m. in your clinic or in my clinic, with the father very nervous, the daughter very nervous, they don't know what to do. So it's 12-year-old girl with the tooth which fell down, is they cannot find it, sitting on the chair. Hold the mic close and speak. No, FI is hypothesis. We're done. Now infer. You know what's infer? Infer is you look at the sky, you see cloud, you say, I infer it's going to rain. That's what infer, inference. Tell us, how do you infer? It's like a prediction, but without any data. It's like just a prediction without any. But what do you expect now as an inference? What do you expect now? What's going to happen right now? Excellent. Thank you. Now, give us the mic. Maybe next, Hayan, tell us what you conclude from looking at this. Can you conclude anything? Whatever. I'm focusing on these elements of inquiry skills. So we just want to develop all these inquiry skills in all of your minds. So it doesn't matter. Any conclusion is fine with me. Anybody has a conclusion in mind? Can you conclude something? Give him the mic.
Usually after trauma, we have a big effect in the bone, and it will be very difficult to put an implants after the trauma, especially because we have, I think, here it's very thin parasite, and the lateral is also it's close to the side, so we need to take care about space on the closure side, the contact point. So it's a really difficult case. It's not the easy one.
So I conclude this is not a simple, straightforward case. That's a conclusion. Okay. Give the mic to Anas. Anas, what do you predict? We are talking about prediction now. What do you predict? She's 12 years old. What do you predict? Mic closer.
I predict she is in the right time.
Okay. What investigation you want to have?
Of course, like we said before, we need to take a radiography or a CT scan, CT and the OPG.
Okay.
Like to check the bone level and also to check the facial and facial.
Fine. What other investigation you think it's necessary in a 12-year-old girl? Give the mic to him. He's talking about hand wrist X-ray. All of you have access to Google. Yeah, at least one of you open your Google and write hand wrist X-ray articles. See what comes up. Have you read any article about with regard to hand wrist X-ray accuracy in terms of dental implant? Maybe you should just open your Google and type hand wrist X-ray in terms of and read the password is OIMC capital at 1234 1234. Yeah. Okay. Capital at. All right. So what the one very important two very important investigation is, give the mic to Dr. Marai. What are the two very important investigations that you will like to do at 12-year-old girls? Okay. Yeah, I think the maturity, keep the, so you ask the parents or the mother privately, how, what do you think, your daughter is mature or not yet? Bulugh in Arabic. And the other one, yeah, stand, make them stand next to the parents and see the height of this patient compared to the parents or the brothers and sisters who are elder to this parents. So these are the more important investigations that we would like to know. Now let us look at the diagnosis photos of this patient. Okay, she comes like this. Mhm. It's 3:15. It's not 9 p.m. We look at the other teeth. She has little decay here and there, as you can see. Slightly, the premolar is buccal. The crossbite is definitely there, but it's not a generalized crossbite, as you can see. It's just this one tooth which is somehow, but her generally, she's not suffering from, she could have better hygiene, but definitely when you look at the molar occlusion, it's a normal molar occlusion. It's just that one single area right here is the culprit. Yeah? Okay. So these are diagnosis photos. Let us look at what we tried to do for her. We tried to do the traditional way because she was 12 and we expect her to grow taller. And we read the articles which talks about implants are only for 18 years old. So we did that. And this is the Maryland Bridge. We cemented it. And before that, cementation, because of the defect, we did not elevate any soft tissue. What we did, we excavated the area. We found a little bit of buccal plate of bone, not much, and we used easy graft crystal and we sutured it. So that's it. Maybe and hyaluronic acid on top of the area, and then we cemented the Maryland Bridge in place so the patient can go back to her routine life. Anybody in this room has not seen how to do a easy graft crystal procedure, this is how we do it. You basically mix A and B, and then you remove the excess, and then you dry the excess, and you inject it in. And you want the bone level to be at the bone level. You don't want to have the new bone graft material to exceed above the bone level. Otherwise, it's very difficult for the actually uh, uh, soft tissue to come and close it. Two things there were, we don't do it the same way as you saw the video. One is the excess liquid should not be left to go inside the mouth. So you put a gauze at the tip and you squeeze all the liquid out. The second thing that we found it recently was that liquid that I throw, you remember the beginning, I just throw it away. Still, by default, sometimes I do that. The smart thing to do is to keep it in a container. Why? Because what is that liquid doing in case you place your bone and it hardens and you don't like the position that it's there? If you take that liquid and you apply it on the bone, you still can move the bone from one place, change the shape. So it's actually giving you a second chance because this material will set quickly, like plaster of Paris. But plaster of Paris, when it sets, if you take water again and you apply little water on it, I don't think you can do anything. It's set. With this, when you apply the liquid, of course, it will not become soupy, but you have some leniency that you can shape it better. For example, it's set on you, and you just don't want that sharp part, or you want it concave, or you want it convex, or whatever. And you looked at it and you say, no, this is not the best shape I wanted. So you take that liquid, you dip an instrument, add it to that bone again, and then reshape it. This is why now we don't throw that liquid in the garbage, which we used to. Okay, so two things wrong in the what you saw. One is we can we cannot leave even one drop to go inside the socket, which I did not really squeeze the liquid out. Second thing, we don't discard. I think the second information was new to you. Okay. Now, you use the liquid, you put in the side.
In the gauze.
No, but the gauze is gone. No,
It's sterilized gauze.
no, but
Dead gauze.
once you put it in a gauze,
Yeah, you can use the gauze.
you can still use the gauze. Okay, now I put it in a container.
Yeah, but in container better, you can use.
Yeah, you can dip it, apply, and then, yeah. All right. So that was the Maryland. Now, the problem is this girl 3 times lost the Maryland bridge in front of her friends. It fell down. Not lost, I mean, it fell down. So the consequences of that, this of course took 2 years for this to fall. We were waiting for 18. So she's 12. We are waiting 6 years for this Maryland too. Yeah, to work. And we did suggest a crossbite. The parents were not interested in any orthodontic treatment. So the issue was here to keep her till she's 18 or at least 16. And then we do a prop. That's why we did the augmentation. And that's why we did an augmentation with a material that is not resorbable. Yeah. So she came in 2 years, her father saying, my daughter is not going to school anymore. She doesn't want to meet anybody. She's not going to school till she is 18 years old. And she doesn't contact her friends. So now it became another issue now. We have a scenario which is more of a psychologically based problem that can traumatize this patient for life. And she would not accept the Maryland in her mouth. That's it. Now we looked into the literature. You found any article?
It says it's not a definitive assessment.
Yeah. So can you give him the mic? Can you read the conclusion? Just say what you saw. See, in most of the articles we read about this 16 and 17 and 18, none of them were actually a study. It was just someone's opinion that you should wait. There are case reports that when they did implants on 11-year-old boys, the boy became taller and the implant stayed in the higher position. For example, the maxillary area stayed higher, and so clinical reports are there. But in terms of using an X-ray of a hand, and that can tell when is that right time to place an implant. Any orthodontist in room in the area? Yeah. Tell us, what is the age that the bone will basically come to an end of growth?
So it's different for the male and female child. So generally we see when it's a female, at times at 12 we expect the
No, total growth, 100%. The articles I read is talking about 25 years old. Some articles talk about 32 years old.
So all the purpose of orthodontics to actually alter the direction of growth, you know, we don't see a lot of changes after age 12 in a female, 12 or 13 being maximum. Between 12 and 13, the most of the time we're talking about traffic parallel expansions to do a lot of our work or regrowth of the, I mean, forward growth of the lower mandible. So we're not seeing a lot of it happening after 12 and 13 in females. In males, it could be between 14 and 16 based on articles. But
A very tight protocol for this patient, which is every 3 months, the patient should come for evaluation. So this is the area that we augmented, and we waited for almost 2 years. And we decided, if possible, we can do a screw retained, a 3.2. Why a 3.2? Because it's easier for me to extract it if I need to change the position when she's 18. So I have in mind, in case I need to do anything at 18, I'll just remove the implant and do it. If not, I'll go ahead. Any of you familiar with this technique? This is making an impression during the surgery using a bite registration material. It's very straightforward, very simple, and you just take this bite registration material, place it on the patient's study cast, and the lab can fabricate a crown. So this is how it is, and this is the soft tissue. You mentioned take it from the palate. I think you were with me during that surgery in 2016. We did it together. I went to the palate. All this came from the palate. We still use 4.0, but for this case we use the 5.0 because you know the soft tissue manipulation is such a critical thing with thin biotype. Yes, give him the phone, the bike. See, if you don't speak loud, nobody can hear you. Loudest. Go ahead. No incision. We avoided the papilla, as you can see. We made a palatal cut here and a small cut here and here, and we pushed the soft tissue buccally, and that's it. No, we didn't do a tunnel here. No, we didn't do a tunnel. This is it. We just used this cut right here. This is the area sutured. See the depression? All the bone I built is disappeared. And I know it's going to get worse. This was one reason why I didn't wait another 2 years or 3 years. Because I knew she is psychologically totally upset. That is her problem. But even if she comes at 17 or 16 and a half, I don't even have bone. See, after 2 years, what happened to my graft? I'm saying have a look. Yes. 6 months is minimum. You can wait longer, but 6 months is minimum, not less. Yes. 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 Not see, it's not question of good or it's matured bone. Yes. We found hard bone which we could drill into it, and this is acceptable because the bundle bone from the buccal area, due to the trauma and due to the falling of the tooth, anyway, it's going to disappear. It's not the fault of the grafting material that I have this depression. It's because of the bundle bone as well as the trauma.
irrespective of what choice you made of the graft, say suppose if you would have put an allograft over there, human bone,
Allograft will be worst because it will resorb faster. Yeah. But I'm saying if you choose the right bone, okay, the correct material, still this is expected. You should expect this depression due to the bundle bone theory, as well as due to the so
and that is also irrespective of age.
no, maybe probably a younger generation will have better healing. That I think because she was young, I have better bone results.
Suppose if we take it to an adult patient, let's say 18 adult. So are you saying if it was a patient 18 to 25 bracket, that age bracket
18 say to 40 bracket
would
will
be
be 35 bracket will be one family, and then Once we start talking about 45 plus, then you know, other, yes. So this is the Maryland in sorry, this is the old Maryland in place, yeah. And the patient goes home from 6:45 till 7:15. Not bad, huh? Okay, so it was not a very long procedure, but it was an important, because I was doing something against all my I was totally, yes. No, because I was sure that I'm doing something wrong. For the last, you know, 25 years I'm doing implants. I was teaching that girls below 16, 18 for the boys is not allowed. And today I'm doing something totally opposite of all the books, all the literature, everything. Now it's 14. So I had to have a very tight protocol. In case something goes wrong, I can fix my mistake. So I was doing everything very, look at this video and then we will listen to your question. So we are placing the implant with the, why I wanted screw retained? Because, yeah, because it's easier for me to remove the implant or remove the temporary or adjust it till I have, my primary stability was not very great, but anyway, I'm using a narrow implant. I don't expect very high primary stability. So immediate loading was out of question, especially in an augmented bone. So she was back on the Maryland for a few months. Time for your question.
Actually, I see we are putting the implants. I see the bone is surrounding the implant totally. But we have the version. It's a good option to put like just the bone graft, just to be like to give you bone.
Yeah, I think what is missing here is not the bone. What's missing here is a thick soft tissue. If we can add a thick soft tissue and have a thick biotype, that will compensate for the thin bone which is on. Because we keep adding bone and the soft tissue is still thin biotype. I'm not sure how predictable is that bone underneath. But to put a soft tissue there, I think that's the right thing to do. Yeah. All right. So we look at that. You know that, you know these, what are these, right? This is diagnosis, surgery, uncovery, restoration, maintenance. This is for all implant cases. And why we put them? Because one of you should say, when we are doing diagnosis, what are the things we should be careful in this case? When we are doing surgery, like the slides you saw, what we should have been very careful. And so as the uncovery, so as the, but why the uncovery is not done? Because we did the impression during the, so during the restoration is just, we have the final crown already, we just put it in. Now, Mike. Yes, we place the healing cap, but not disturbing the Maryland bridge. They shouldn't touch the Maryland bridge. And the question is, during the surgery, what are the things that you think we should be very careful? That, yeah. Okay. Putting the palatal position so screw retained. What else? Preservation of the papilla. The diameter should not, should allow at least 2 millimeter of buccal and palatal bone. Slightly below the bone crest because of the expected resorption and the future of the surrounding area. Okay, that's good. Now let us talk to the uncovery is done during surgery. So let us go to the restoration. So this crown was made when? 1 week after the surgery. But we didn't install it because of the bone. So the patient comes and we try it on, it's fine. We check the Ostel, we have a 66, which is not great, but since it's above 60, so it's acceptable. And we send it to the lab for some staining. It was too bright. And the patient comes back. Let's see a nicer shots. Yeah, that's it. So this is it. This is the best we could get with the. Now remember, this is a cross bite, and this is not. So it wasn't easy to fabricate something which will be. This is the final restoration. 2 months after we got 66. 2 months. Yeah. And then maintenance phase, the patient is asked to come every 3 months. Now, how we do the maintenance phase is we want to check the soft tissue around it every 3 months. We just don't want any X-ray. We are making an impression of the X-ray device. Let me go back. There is a putty impression here. So when the patient is biting after 3 months in the same device, the X-ray is perpendicular to the long axis of the teeth the same way it was 3 months ago. So we can do something called subtractive radiology. This is who? Okay, so you have to be angulated. Yeah, you have to be at least, say, 20 degrees like this. You cannot push. Yeah, no problem. If you're from here till here, see this? The nerve is this one. So if you're till here, it's fine. If you're not sure, the first drill, take a CBCT. Yeah, so you have 14, so you go 13 millimeters, and don't use a wide one. You will not perforate. Say 3.7. What system you're using for this? By Horizon 3.8 by 12. Okay, so regarding the radiography, it's for her. This is saved in her file. When she comes every 3 months, the same thing is opened and the same angled X-ray is taken. The second thing we are doing every 3 months or every 6 months or every 1 year. Now, she comes with her parents. Imagine she has to come with her parents. She cannot come alone with the driver because we need a photograph. This was at the time of the restoration, and this is 6 months later. And this is the photo of we're comparing the height between, between every 6 months to see if there is a difference. So this is how she smiles. The crossbite is still there, and she's encouraged to fix it. But at least she goes to school. She's back to every, life. And you remember this gingiva was below this gingiva? See, it's higher now, which is not good news because it's a thin biotype. But if we can maintain it here, great. If we cannot, then we have to cut this ceramic to allow it to grow more downward. It will grow slightly if you allow it. So I think even though we crossed the limits, this is after 6 months. See, the gingiva has slightly gone higher. I think it's due to the bulkiness of the ceramic. If we remove this ceramic, I think it will grow a little lower. Yeah, that was the other measurement I expected one of you to say. The mesial distal space is the first measurement. The mesial distal space of this area versus this central is different. So one option is to add ceramic or laminate or something to this tooth, or add to this tooth to make this mesiodistal space and this central to be identical. Which restoration? Yeah, because the mesiodistal space here should match the width of the central. Now let
Maybe she had the space before when she had the tooth between the lateral and the
probably I don't know. Yeah, could be. So this is how she walked in with the accident, after the accident, straight from school, and we were not sure if there is any remnants of the tooth because of the panoramic view is not sufficient to tell us. See, it's not definitive. So with the periapical is sure there is nothing left inside.
it's fully
It's fully avulsed. And this is another radiograph from another angle to see if we see something else. Same, we didn't see anything inside. This is after the bone graft was placed in the socket. This is we are not drilling the bone at all. We are expanding it because we want to preserve every part of it. And this is the implant in place. You can see the level of the bone. This is a healing abutment. So the implant is here and the bone is here. We don't want to go too much deep because if the patient grows taller, the bone is gonna want to come lower and the implant will keep sinking in. And because it's a kind of a platform switch, so we thought the bone will stay here. This is point zero, but this is not acceptable. The restoration is the time you start. This is point zero. Because before the restoration, point zero has no value. Because the restoration will affect the bone level at the neck of the implant. So this is point zero where the restoration is placed. This is the implant. This is the bone. This is the crown, the margin. And after 3 months, there is some remodeling here especially, but still the bone level is fine. It's still fine. So we didn't find a difference, and this is after 3 months. Point zero means where you start calculating. So basically, this is one radiograph, 3 months, 3 months. So till now, you remember the platform switch corner? We, of course, would love to have it here, but still it's within the limit. And I think the reason for this to be successful, because she's not growing taller, and we have crystal bone here, and we have crystal bone here. Because of these two things, she's not growing taller, and we have crystal bone in both neighboring teeth. That's why nothing is changing. The only thing will change is the soft tissue, okay, which we hope she will allow us to, her parents will allow us to change from a thin biotype to a thick biotype. This is 3 months and 3 months and 3 months. So this is 9 months. Yeah, there is a remodel. We don't call it resorption because the bone level is still here. Yeah, from here, it has come maybe like less than a millimeter here, but here we still have the bone there. So I don't think this remodeling is definitely happens. There is no way you can avoid that. That's why the less you vibrate the bone at the time of implant placement, the better you are. And I'm very happy with using expanders instead of vibrating with the drill, if I can. So that's it. You want to go back? You want this? Don't use a flash though. It's clearer without a flash. Okay, so we have this. Now let us continue. So the concept was anterior defect. Let's have a few questions. This is how she was, and this is how she is right now. Okay, now who's having the mic? Read the question loud and clear. Stop. Whoever says whatever answer they want to say, remember your answer, because when you see the right answer, we want to see. You want to answer? Give him the mic. Everybody can answer. Okay? Okay. Anybody has more answers to this question one? Anyone? Abdurrahman? Any comments? Okay. Read the second question. What changes you expect? Abdurrahman, be ready for answering this. Give me the phone, mic. Give it to Abdurrahman. What else do you expect in immediate implant placement? You extract, you place. What else you expect to happen to the bony architecture versus non-extraction socket? Yeah, I think this is a must. There is no way to avoid this. The only thing you can avoid is if you have a gap between your implant and the bone, you fill it with some kind of bone. So when you lose that buccal bone, the resorption will come and stop at your augmented bone. So to pack bone, if yeah, it will sure happen. Unless you have a 2 millimeter of thick bone, you have less chance of that happening. But if you have a thin bone, which normally we do, in the average bone available in most around 65% of population is 0.6 millimeter. That article is already available. So if you have a gap between your implant and the bone, fill it up, because that's what is going to stop when the bone resorption is happening and the soft tissue are coming and they're eating that bundle bone. Then they come and they find a good prey on Friday. Nothing will happen. You keep bending down and kneeling down, nothing is going to happen. You reflect less than 2 millimeter or say less than 1 millimeter of bone left, you have to place bone there. Because by default, every reflection, you lose 0.5 millimeter to 1 millimeter of bone because you already removed the arterial supply from the periosteum. So you have to have some, to every action, there is a reaction. So the reaction is bone loss. You cannot open a flap and then don't put anything. You cannot. Unless you have 2 millimeter of bone. Yeah. Yeah, all this is anterior. Posteriorly, normally you have enough bone to deal with. Titanium mesh, if you can place it in a very a way that the mesh doesn't perforate the soft tissue, it's a very good idea. The only problem I see is that doctors don't evaluate the biotype and they put titanium mesh for everybody and then it perforates. So for a thick biotype, I think it's very, very good idea. For a thin biotype, unless you know what you're doing and you're covering it with PRF or something to protect because thin biotype easily can be lacerated. So if it gets lacerated and your titanium mesh basically is exposed, then you lose everything.
Dr. Why we have kind of mesh, we have this problem that it's really, we don't have exposure to the mesh because they have this small bones.
No, it's just the you put any metal object under a soft tissue, okay? It will, I mean, the soft tissue is like less than 1 millimeter, so there is a good chance that it just perforate. It's just a mechanical friction. When you have a thick biotype, we talk about 2 millimeter of soft tissue with keratinized surface. That doesn't happen. Okay. 3D printing bone. It's 3D milling bone, which is available, and hopefully we will do that in December for you to see a case where you send a CBCT to the lab, and they send you the shape of the bone you want based on your design, and you just screw it in place. That will be more predictable than titanium mesh. Next question, since you're holding the mic, can you read it loud and clear? How would you make a surgical guide for this case? I think there was. They should have been. I didn't show it, but there must have been CBCT.
We could use the position of the Maryland,
Okay.
the findings from the CBCT,
Okay.
and based on that,
One very important thing is the CEJ of the future crown should be in the surgical guide, because if you want to be 3 millimeter above that, you need to know where is your future crown, because you want to have from the implant to the crown margin, you want to have something called emergence profile. That means from a 3 millimeter suddenly to a 9 millimeter diameter crown. That's a big difference. So you want to know when are you going to become, like, when is this emergence going to happen? So you need to know where to put the implant. If the implant is too far, it has its problem. If the implant is too low, it has its problem. So you want to be approximately 3 millimeter below, or in this case above, the CEJ of the neighboring teeth, which is the CEJ of the future crown.
more in this case.
No, it's not more.
You said more in this case. More than 3 in this case.
I will have to listen to it. Why? No, I'm saying 3 is average. You can be 3.5 or
You're saying the neck of the implant should be 3 millimeters
above the CEJ of this crown. The neck of the implant should be 3 millimeter above the neck of this crown. Above, not neck of the below, above. Yeah. Mike.
If you open the wound and you found the future implant will be more than 5 or 6 above, that's not an junction.
The future implant
You couldn't find the bone at that level. Your preferable
position. Okay.
So what you do?
Then you put it in still 3 millimeter or 4 millimeter, between 3 and 4 millimeter, and you build the bone at that visit.
You build it vertically.
Yeah, because it will be supported by the implant itself. Like the implant will be like a pillar, and you build bone around it.
And you will get that bone.
Up to 2 millimeter, you should get that bone. And then
So you will have the implant like above the bone
a bit,
and then you cover it with the
bone graft. What he was saying about titanium mesh up to 2 millimeters. What he was saying, titanium mesh, and these are the techniques to create that 1 to 2 millimeter of vertical bone. More than that is not predictable, but within 2 millimeter is predictable. It will not, it's not a question of what will happen. It's just the neighboring uh, bone. If they stay there, fine. But slowly, if they resorb, then you take the papilla slowly to the level of the implant. Slowly, everything has to come to that level by time.
Eventually, you have a recession in digestion.
Yes, eventually. Also, it depends on what's the diameter of the bone between your implant, and if it's too close, it's more quicker eventually. If the implant is thin diameter and the bone around it is 2 millimeter thick bone, you know we want 1.5 minimum. Yeah, so if that is 2 millimeter, the chance of you going deeper and nothing happens to the neighboring teeth is high. So it all depends on the surrounding area. What about long abutments? Give him the mic. I don't understand the question.
If you put it deep, not in the position that's on. If you put it deep, instead of leaving 2 millimeter above the bone and then putting longer, you put it deep and you put a longer off. Is this acceptable?
Wait, a long abutment, how would a long abutment do anything? The bone level will go to the first thread of the neck of the implant, irrespective of the crown and the abutment on top of it. Wherever is the implant, the bone will go to the first thread, the bone will remodel to the first thread of that implant. So you have long abutment or short abutment, how would that make any difference?
I mean, to keep the same for the CAG. So we want the position that you talked about. That this is the perfect position to get the CAG with the neighboring teeth.
Okay, see, this is the implant level. Okay, it's placed 3 millimeter below the CEJ of this. If you put it here, the bone has to resorb till here, no matter how long is your abutment. He went Hayan.
There was a case where it was a compromised case, no, it wasn't ideal. And you said that it's one of
This is also a compromise case. If this patient was 18, it would have been ideal. But because she's 12, it's compromise. But then the second option is do nothing. And the bone will resorb more, and she will not go to school till she's 18. So this is not an ideal. Don't go after this lecture and say, all 14-year-old girls come to me because Dr. Suhail said all 14 years old girls are welcome for, I will only do implants. Even if your teeth are there, I'm going to pull one tooth and I'm going to just put an implant because you are reached puberty and hopefully you're as tall as your parents and come in. No, this is a compromise. We are checking her. We are checking her every 3 months. To come to a clinic every 3 months itself is a compromise. Yeah. Now ask the question.
yeah, there was a case, it was a posterior ridge, it wasn't the aesthetic area. Where instead of, now you're trying to make 3 millimeters to the CAG. But in that case, you showed us a long one, where it was all the junction epithelium, it was a long junction epithelium, and it was stable, it wasn't unconscious. And the patient had a crown, and it was like a mind occlusion to not have to make any.
Yeah.
There was 8 millimeters.
See the bone level. The bone. See, we could not achieve because the neighboring crestal bone was not there. So even if I attempt, first of all, 2 millimeter of bone building there was not possible. Yeah, and that was 5 millimeter below the bone level. So I kept the implant at bone level wherever it was, and I didn't do bone grafting. okay? Because the bone graft depends on the neighboring crystal bone. There was no crystal, there was a flat bone, right? Actually, the canine was worse. So in that case, I placed the implant where the bone was because I couldn't make a vertical augmentation. I knew it will not work. And then making the soft tissue thick and not touching the papilla and using a platform switch concept made my work successful. I solved the problem of 8 millimeters of bone inefficiency or insufficiency by using a platform switch concept. Is that,
Yeah, this is just like comparing.
yeah, that is a platform switch, yeah. Yeah, but with 3 millimeter 3.2 millimeter implant, I will not be getting a platform switch, because what is a platform switch? The diameter of abutment is smaller than the implant. Already this implant is considered the smallest. For a central incisor, a 3.2 is the minimum you can do. Even a 3 millimeter is not advisable here. So if you have a 3.2 millimeter implant and you want to use a platform switch, you're talking about what? A 2 millimeter abutment? It doesn't exist. So this is the best available thing that came to our mind at that time. Next question. Yeah, one more thing about the surgical guide. You want to have the access hole, and you want a palatal, but you want to have it in your surgical guide where is the best, and you want a line on the surgical guide where that line corresponds the way you hold your drill. So these three things are mandatory: the neck or the CEJ of the future crown, where the hole will enter, and a straight line which you will parallel it to the osteotomy when you're drilling. So you will not go mesially and distally, because you have a line, you just parallel yourself to that line. These three are definitely, remember your answer, because when we discussed last question, who's having the mic? Read the last question.
4 ways to replace a missing completed tooth for the child or teenager.
Yes, tell us 4 ways. Okay. Okay, RPD you mean? Okay. Actually, correct. It's what you said was better than RPD, because we are trying to stay away from short forms. And go ahead. Removable partial denture. Okay. Okay, 3-unit bridge. Bonding. That's a Maryland. Fiber, yeah, using a fiber mesh. Yeah, it is a variation of a Maryland. Using a? Yes, using an ortho wire labially. Labially, orthodontic wire with brackets. Yeah. Yeah. Mm-hmm. 14 years old. Yeah. Yes. Yes, so that's the fourth option. Okay. Okay. Just to humor you with a quote, you read the quotation. Give me the mic. Sometimes, read us the quotation. Yeah.
have an option about my smile?
Option?
Opinion about my smile, please raise your hand now. Put it over your mouth.
What do you think of this option? You agree or disagree? This is just the humor, because many times you have a person who comes with the patient, like a sister or a grandmother or somebody, and really they confuse the patient and you, and they keep saying, no, no, but why if it's not longer, little brighter, little yellower, and the case doesn't go anywhere because of so many new opinions. Sometimes it's very wise to tell them, you know what, let the patient decide, and that's it, because too many opinions sometimes make it difficult. uh, one, yeah, he has a question.
The first visit when the patient comes, you found any buckle bone?
There was a thin buccal bone, yes.
You remove it or you keep it?
No, it wasn't all the way to the crest.
Yeah.
We lost, yeah, there was few millimeter lost.
On the graft, you fill the whole socket with the graft. That's it.
Yes,
No membrane, nothing.
nothing.
If we want to use allograft, mixed with the hydroxyapatite.
Then you need to raise a flap
Yes.
and place a membrane.
In that case, you will lose a soft tissue.
Yeah, but you overbuilt and compensate that.
And the compensation will be better than
Yes.
using hydroxyapatite. Let's say
See,
in the
it's
short term. I mean in the short term. For
see,
time.
see, both have advantages and disadvantages, right? For this girl who was traumatized and you wanted a simple procedure which will work, this was a very acceptable technique. If the defect was worse than this, then I need a block graft, or I needed 6, 7 millimeters of bone graft. I would open the flap, I will put more graft than I need, expecting 30% loss, and I will tent it with a non-mobile membrane, put pins, so I immobilize the graft, and I will suture the area and wait again 6 months. For this amount of bone, this was a simple procedure which worked. So little more defect that I could not have used this technique if the defect was bigger. Okay, all of you know William Shakespeare. The reason I put him on, he talks about in his most famous 136 sonata poem, he talks about how much of an aging has effect on people's accepting you in the society. So since age is an issue, I thought that poem is very relevant. So if you get a chance to go and read this poem called 138 Sonata, it will be interesting. Now, to evaluate your knowledge, experience, and skills, there is a way we could do that, and we'll come back to this. Let us go over the questions, and then we'll come back to this. Okay, now I think for this we need, if somebody can run to get paper and pen, we should have pens there. We should have also paper. Can you check if there is a bundle of paper? No, bring it with the base. Bring it with the. Yeah, I want everybody to have one paper. Is it empty? If it's not, okay, use the back part. Just take one. No, no, take one. Just cut all the papers. Use the back part. Is everybody have one? If not, take one more. Does everybody have one? Is it enough for everybody? We got enough here. I'm done. Nashat? Okay. what I want you to do, basically, you have 5 scenarios here. Okay? Now, in these 5 scenarios, I want you to draw these 5 scenarios, and in all of them, draw for yourself where will be the ideal place to place an implant for 11 and 21, 11 and 21, 11 and 21, 11 and 21, 11 and 21 in this scenario. So this is the existing scenario. The patient comes to you like this. Draw this and place the neck of the implant. Will the implant be here? Will it be here? And for this tooth, will it be here? Will it be where? Can you? We're talking about CEJ now. We're not talking about bone. I'm talking about Shakespeare's aesthetic points and our golden proportion points, and from the CEJ, okay, of this tooth is here and 21 is here. Where, if you want to place an implant on this tooth, where will it be? If you want to place an implant on this tooth, where will it be? And because the tooth is here, you expect the bone to be 3 millimeter above that anyway. Will you consider them to get, if you're placing 2 implants for this patient, will you place the implant in a different level or in the same level? Which one you choose? Can you draw? I think this one is same as this. So draw only 4 scenarios. 1, 2, 3, 4. Draw 4 scenarios and tell us, once you're done, I'll give you a laser pointer and you tell us what do you think. That's the rule, but when there is a difference between uh, right tooth and the left tooth, then it becomes a little bit of demanding of which one you choose. So my question is, what if it's not in the same line? Now, okay, right, then write gingivectomy in your plan. The point is, I want to open your eyes to where the implant should go. Okay. Whoever is ready can go first. People who are watching, they can grab a piece of paper and do the same thing with us. Draw these 4 scenarios and draw where the implant should come, and let's discuss where is the ideal place for the implant and why. Don't spend too much time on the tooth. Just draw the neck and draw the implant. Draw the neck of 4 scenarios and draw the implant accordingly. Okay. These teeth are the future crown of the patient, okay, which you can change. Yeah, okay. The easiest way, yes, they all will be removed. These centrals will be removed. Okay. Should we start discussing? You still can see with this light? Yeah? You want light? Anybody who wants light? Okay, ready? Or not yet? You ready? Okay, if you don't need light, leave it. Okay. Okay, let us give him the mic and this laser pointer. The battery is on. It will be finished. Yes, give him both. Okay, now we're talking about the upper left, is it? Let's start with this. Yeah. Okay. 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 So if you're placing an implant even only here, imagine you're only placing it here, and this tooth exists, you will. So you add 3 mm on top of this, and then you place the implant here. Same you will do for this. Thank you. At the line below, at the line above, 3 mm above. This is where the implant will be. Anybody has a different opinion? Raise your hand so we can discuss it. No different opinion? So you place it, you place the implant here, okay? But if the tooth is already here, the previous tooth, that means the bone is here. So you'll place it below the bone level, and you'll augment. So if, yeah, so if the tooth is already here, there is no way the bone is also here. Cannot be. The bone has to be higher. In this case, maybe the bone is lower, but I think when you say you cut the gingiva, it's not a bad word. It's not like a, it's not like an insult or disrespectful word. But there is a better terminology. It's called crown lengthening, which is different than just gingivectomy. Crown lengthening means you keep an account of the position of the bone will be 3 mm away from the position of the neck of your future crown. That's crown lengthening. So you remove the bone to a level where you allow 3 mm of biologic width for the future crown or the future implant. That's where you are. Yeah. Yes. Crown lengthening is predictable. But just to cut the gingiva and then hope that everything will work out.
Doctor, we do we did the crown lengthening, we placed them, we get more resorption than what we expected.
No, but no. If you're doing a single one, if you're doing a single implant or double implant, what are you doing?
Single implant.
Okay, if you're doing a single implant and the bone level of neighboring tooth is here, and you place the implant at this level, all right, as years go by, if there is a resorption, then because you have to make this tooth matching this tooth, correct? You have to make this longer. Otherwise, it will look awkward. If you make this longer and your implant is here, the neck of the implant will show a gray color and it will not look aesthetic. So you have to place your implant here. If you don't want to do crown lengthening, at least you will go 3 mm below the bone level
That's correct.
and leave it What if the bone doesn't resorb? Then you have to cut the bone.
Yeah. But at that time, I'm sure that
I have a case which I did what you said and I regret it. I will show you next week.
because this only depends on the level of the bone. Like if the level of the bone,
Give him the mic, please. Louder.
if the level of the bone was good, we have a good level of the bone between the two centers, then we don't need to remove bone from the
No, the point is the point of this exercise is you pay attention to the prosthesis, not pay attention to the bone. Where is the final margin of your final crown will be? Then you decide where is the implant will be, not where the bone is. Maybe the bone is here. Don't put the implant here. This is the exercise. Yeah? She needs a mic.
This case, similar to the case which you showed just now, that 14-year-old girl,
Which one?
which
This
we
one?
discussed, yeah, because initially you placed for the implant, the gingiva was below. Then
The,
after 9 months, it decided and came to almost similar level of the other centers.
yeah, but in this scenario, you're right. In this scenario, the trauma also played a role in losing that bone because she had been hit. So trauma was against us. Yeah. Yes, it's somehow close to that girl. All right. I think it's clear about this case. Let's go to.
Do we need to consider the gingival height of the lateral?
Yeah, of course. Yeah. If.
If you put the implant little higher, central is too much longer.
Yeah,
Comparable with lateral.
definitely. You have to pay attention to the position of the gingiva here. But if this central is here and the bone is here, all right, and you're placing two implants on this area and you do an augmentation and you don't get the bone that you built and the neck of the implant is showing, then it will be very ugly. But if you place the implant 3 millimeter above the CEJ and here, and you do little bit of gingivectomy to match it, it's safer than expecting vertical bone augmentation to happen. So my point is in the anterior area, vertical bone augmentation is not predictable. It's very risky to put the bone here and bring your crown down. What if you don't get this bone? Also, it depends on the crystal bone. If there is, if the lateral has bone till here, then you are right. Maybe I will place my implant here, and I will bring the margin of my future crown here. But it all depends how low is this bone coming. But if the bone is up here, I think I will raise this one slightly higher, and make 1 millimeter gingivectomy here and bring this. Yeah, depends on the thickness of the gingiva and the amount of bone available. It's like this case and this case. This is definitely, you can do gingivectomy or crown lengthening to make sure this is an exaggerated central, like too much, and this is too little. Somewhere in between will be ideal. What's the average length which is acceptable by human eye? 10 to 11 is acceptable. And width, 8.5 is acceptable. So always a human eye can accept 20% difference between height and weight. I mean, height and width. So if something is, say, 10 millimeter, a human eye can appreciate an 8 millimeter width, the golden proportion. The eye can appreciate, can like it. by default, because most of the things we see is like that, maybe, I don't know, whatever it is, the background, but that's what it is. Okay, let us quickly go to the second case. We need a mic. Give him the mic, please.
The southern edge of this central is a little bit shorter because it's like lateral, which is this one is the correct one. So I think we can consider this is the correct one, and if you want to put the implant, we will take it from here. Also, this one we will take from the same. So not follow this one and make it deeper. So we will take this one as the correct one and take 3 millimeter and put our implant here.
Anybody disagrees? Okay, this was definitely correct. I think this has to come down, and 3 millimeter from this position will be the ideal place to place the implant. Next is this one, which is slightly tilted. Would you place the implant tilted like this, or would you place the implant straight?
Actually, this one is it's depend on the lateral and the central if you want to put the implants here. So in case if the lateral have also tilted roots, so it's better to put it also tilted. But if I have the room, it's good, so I can put it straight. It's not mandatory to make it tilted. But I think the most important is the lateral and the central, and to put it in position to be like matching this tooth.
Okay, imagine this is the implant you are replacing,
Okay.
and this is tilted. Will you place the central straight, or will you place this tilted? This is the patient's existing tooth.
Okay. No, I will put it straight. Same.
So this will be straight, this will remain tilted.
Yeah, I will follow this one. So it will move also.
No, no, no.
For example, if I have this tooth is extracted, I will put it in the same position of this one.
Okay.
If this one is extracted, maybe the lateral have also some tilted, so I will do it also tilted. So I will follow the position of what I have from before.
Anybody else? Any other opinion? Orthodontist's opinion?
Given an option to straighten it out, I would, but if it's just extracting and putting, why not put the implant straight?
Yeah. I think
Especially restoring it and we're going to make, when you restore it, we make it to ideal.
we try not to follow a crooked tooth if it was crooked before, unless the patient comes and asks for something which was there. I had a patient who asked for a 4 millimeter diastema, and I told him it's not going to look nice. He said, well, I had it for many years. So I told him I will close the diastema, and then if you don't like it, I'll open it again. He agreed with me. He went to his country. He came back after 6 months. He said, I don't like it. So I made a 4 millimeter diastema for the guy. And then he never came back. So some people like, something which is to us is not beautiful. Who wants a 4 millimeter midline diastema? Okay. Okay. So, okay. So for those people, if he wants it tilted, fine. But I think if we can make things straight, because if somebody looks at this patient and says, "Ha, you did this implant?" He say, "Yeah." He said, "Yeah, yeah, it's obvious. I could know." So everybody knows that this is an implant. Why? Because it's crooked. So implants are crooked. No, it doesn't have to be, unless there is a reason, maybe the root of the next tooth, or whatever reason you cannot, which is very rare. Because even if the key is sometimes we misunderstand the the crown doesn't have to match the parallelism of the implant. The implant can be straight, still you can make the crown crooked. The implant can be crooked and you can still make the crown straight. No, actually, see, if you look, the lateral, both laterals are crooked to the left. None of them are straight. So that means everything is crooked except this tooth, which is opposite. So this tooth is straight, this is crooked, and this is more crooked. So if the patient is not going through orthodontics, I think you should stay somewhere in between where nobody notices so much out of alignment. This is crooked, but it's, not very clear. This is also crooked, but it's not very clear. This is straight and this is over. So I think something in between that the human eye cannot detect, that things are out of balance. Yeah, to make it crooked. Okay, fine. Okay. How you want to do orthodontic treatment to make something straight crooked? Okay. I think no, I think I will make not so much angulation, but because everything is not properly aligned, and if the patient doesn't want to do orthodontics, I will do something in between this and this, somewhere there, where it doesn't show that this is the only 100% straight teeth and everything else is crooked. Or I will just copy paste the opposite side. If I'm doing this, I will copy paste this. And if I'm doing this, I'll copy paste that. Because the midline and then and the two centrals they have to be copy paste. That's the best thing to do.
This is you are eliminating the orthodontics.
But the patient doesn't want to do orthodontics. Why would he replace his centers if he had a healthy enough tooth to do orthodontics? If he had a healthy enough tooth to carry forward orthodontics, why would he come in for an implant? Well, imagine.
Okay. Does the angulation of the implant affect with the new technology, new angled abutment, dynamic abutment, multi-unit abutment? Really, that affect and searching for a bit more while we drill it. Do angulation, whatever we want, and better than do monograft or stick to a normal alignment or straight.
Uh, uh, no, the
Does it affect?
yes. See, the position of the implant is very important. 2-3 degrees sometime. You say we have angulated abutment, but the angulated abutment immediately takes the option of screw retain to cementable. As soon as you go to angulated abutment, you removed all the advantages of screw retain.
Now we have dynamic abutment, multi-unit abutment.
That, well, my multi-unit abutment, you have to have at least 4 millimeter of soft tissue to cover that big, thick multi-unit abutment neck.
Yes.
Minimum
Yes.
4 millimeter. Maybe this case doesn't have the implant is not placed 4 millimeter deep.
No,
So,
I mean, doctor, the
so
angulation.
wait, let's go to the third one. You said dynamic abutment, which you can put the screw 15 degree to 20 degree off axis. At today's world, we have only maybe 2 or 3 companies who have that abutment. So if you're dealing with systems that don't have that abutment, you cannot use this dynamic abutment. So if you can, think of the prosthesis first and then place the implant to match that prosthesis, definitely you're on the right track. Versus you put the implant and then decide, say, I have so many options. I have 3 types of abutment. I somehow will figure it out. No, sometimes you cannot. And also these angulated abutment is not you can put it anywhere. You have only 6 choices. If one of those 6 choices are not exactly matching where you want, then that angle is not matching where you want. And also you took the advantage of screw retain from the patient immediately. So I think still we have to pay more attention to placing the implant exactly where it should go, and then worry about the prosthesis, not just place where the bone is, and then we will figure it out by using a different abutment system. With your, give me the phone. With your experience, what do you think? Is this statement uh, valid? That you try to still place the implant where it should go according to prosthesis versus,
This is what I think.
what do you think? Tell us in detail.
Put the implant where should the prosthesis be? Not we put the implant where we have both.
Because many times the prosthesis cannot go where you want it to go based on the position of the implant.
Especially a single implant.
Yeah, what I asked, if we have two options, bone graft, we have two options. Bone graft, build a new bone at the implant, or place the implant with a sufficient bone. I mean, with what we have option as abutment, as the prosthesis. That's
Okay,
what I said.
I think if the bone grafting you're doing is predictable, is horizontal, we would do the bone grafting. If it's vertical, then I agree with you. We try to manage prosthetically because the bone grafting for vertical is not predictable. But if you have a predictable bone grafting, then you do the grafting, place the implant where it should go, and give the crown where it should go because it will last there. And if it's all this cementable prosthesis, if I can avoid it, why not avoid it? So I'm a person now of prosthetically driven, not bone driven. That's what I think.
And my question is the angulation of the abutment affect the stability of the angulation of the implant affect the stability of the implant?
No,
I mean on the load?
no. Today's world, uh, five, 6 years ago, that was a big debate between people who placed implants in angle and said that the off-axis load will be multiplied because of the studies they do on models. You know, the photoelastic studies and finite element studies, they show that stress will be much more when you have an angulated abutment. But somehow with the human body, they found all those studies is not matching what happens in the clinic. That's why these short implants, these 45-degree implants, are giving good results. So now that theory is being removed. So angulated implant will have no difference in terms of primary stability or accepting the load versus a straight implant. All that is being removed. It took 3 generations to remove that theory because till 5, 6 years ago, that was a very big debate. Half of the people will say this, half will say that. But the last 5, 6 years, everybody is 100% convinced, especially with the 45-degree all on four, that there is no problem with putting an implant angle or putting a short implant. Yeah. But of course, when you say angulated, we are not meaning narrow implants. It might break. When we say short, we mean like deep, wide, and deep fins, not the one with the you just take a normal implant and make it short and put it in. You have to have deep grooves in same, like a Bicon system or something which has very deep grooves. So I'm not saying take one part of the fact and delete everything else, but 45-degree, 13 millimeter, 12 millimeter, 4 millimeter diameter implant can withstand as much as load as a straight implant can stand, if not even more. The last scenario, let's go quickly. There is not much a big difference between this and this scenario. The only thing here to pay attention to is, yes, is recession. If the recession is there and the dentin is exposed, that means thin biotype and no bone here. So the bone is here. So still the story, the result is the same. Is just pay attention to the gum here, and probably you don't want to make a lot of vertical incisions, You just want to stay with minimum touching the soft tissue, maybe PRF, maybe soft tissue augmentation. Otherwise, this scenario and this scenario is identical, the same. So all of these drawings that we put is definitely wrong because they cannot be there. This is unacceptable. All right, let's, who has the mic? Can you read the answer? I mean, read the question and the answer. Whoever answered.
What soft tissue changes would you expect to see in single maxillary anterior implant?
Wait, who answered? Nashad answered. What did you answer? No, what did you answer before? Okay, say the answers you said. Now read this one. The answer. So the second one you answered already. The first one, none of us guessed it. You said black triangle? Okay, you said it in your mind, which is good. Okay.
In this scenario, you have restriction with the papilla to make contact point with more adequate.
Yes.
So we have
An illusion of papilla. Yeah. Next question.
Excuse me,
Yeah.
how about in such an aesthetic area, we go immediately thinking about the pink ceramic,
Some patients, sometimes it's acceptable. Sometimes it solves your problem. Sometimes you cannot get that color and the patient doesn't accept. Sometimes it solves you. Sometimes it doesn't. That's your last option. Yeah. Next question.
changes according to the mode of the pictures following immediate implant placement into an extraction zone.
Abdurrahman answered that question, right? Give me. Wait. What was your answer? Okay. Read the answer here also. So this is something that you should expect. 50%, that's a lot of percent. 50% and 30% lingual. Why lingual is less? Thick biotype, and there's no frenum. There is nothing pulling the palatal area. Only buccally, you have frenum, you have movement, you have muscles, you have lips. Moving, pressing and pulling. Resin bonded, you said Maryland. Okay. Adding to patient's retainer. This is a, a removable retainer. That part we didn't say, maybe. That's the only part we missed. And the fourth one is, we mentioned. Yeah.
I think when they say auto substitution, they're talking about drifting another tooth into place. Is that?
Moving.
Yeah, auto substitution could also be drifting another tooth into that place. They won't immediately. No.
4 ways to replace a missing clear tooth on a child.
So you will drift the lateral in the center and then ground, and you will destroy her life.
Well, sometimes when a patient comes with a missing lateral, there is an option to bring the canine and then place an implant on the, yeah. So it's good. Then add the fifth point, which is moving the transposition of the next tooth, which is good to add. Yeah. All right. So in this 1 minute pending, I just wanted to show you something here. Yeah. Let us talk about knowledge, experience, skills. Let's take one. Let's take skills times knowledge. Okay, let's take knowledge. Did you get any article? Not yet. Anybody got an article on this topic of below 16? What is the youngest age to place an implant?
Last time we checked.
Sorry?
Last time we checked it.
We checked it? Okay.
I think it was.
So we did this before with your group?
Yeah.
I didn't know.
Yeah, but not in this case.
Okay.
We saw this case before.
Okay. Skills. Let us talk about skills. Now, in terms of confidence in placing implants on a 14-year-old girl on a central incisor, okay, zero, none of you are confident. 10 is 100% you're confident. Okay? Give the phone, give the mic one by one. You pass on the mic and keep saying your opinion, pass it on. Say a number. One. Next. Five. Wow, you're good, confident. Zero. I'm still, even though I did one case, I'm still not confident because every 3 months I'm really worried what's going to happen. What if she grows taller? So I'm still at one. I will not do this as a daily. I shouldn't have said anything. Four? Four. Your opinion. How confident you are to do this in your office? Abdurrahman, 10. Yeah? 10? 10. Zero. Okay. Good to know because that's to how to evaluate. The point is, we want to evaluate your knowledge, we want to evaluate your experience, we want to also evaluate your skills. So for you to evaluate, we found this way. You look, at your skills and say, you know what, to do this again, I have so much confidence. And then slowly you increase. The more you do, you increase your skills. This is how you evaluate your own skills. Because many people say skills is not quantitative, it's only qualitative. Now we made a formula how to quantitatively measure your skills. So this is one way. You can quantify your skills. Thank you very much. It was Mike. Huh?
I think the correlation has to exist, right? Based on the experience that
Yeah.
your skill set keeps improving.
That's what. How many times you do it? I think the times will make the experience increase. And it's related, yes. If you separate it, then it will not take the shape of the ridge or the socket. So it will always be a gap between your bone and again the granulation tissue will flow and you lose the purpose. The whole purpose of this is when it's soft, you put it in, it hardens and doesn't allow the granulation tissue without membrane. Thank you very much.
Of course.
Which one you want?